All right. Welcome and greetings from Mount Sinai Hospital and to our Indian colleagues. Everybody can see and hear us well. I don't have
Yes,
any
yes,
response from other side. Oh, you can hear,
Yes, we
right?
can
And
see
can
you and
see us.
hear you.
Good.
Yes.
Okay, beautiful,
absolutely. There
beautiful.
must be some delay, so you'll have to bear with us, maybe a second or
Of
so.
course. Yeah, always there is yeah. And of course, we start with the case today, and we invite all the panelists who are coming and my co-moderator. Good. No, go to the previous slide. I think we already got to the second slide. Good. So this is and put things on the one side. So today our goal is on the bifurcation coronary lesions in the rota cut approach with the imaging, high definition IVUS guided, rota cut approach, and of course supported by Boston Scientific India, ESCC Jaipur, and Mount Sinai Hospital, New York. We are asked no disclosure. This is a 78-year-old male presented with the class 2 angina and positive CTA and stress positive. And then here, risk factors usual. Patient has a CAD, has a stent in the D1 and LPL in 2011, 13 years ago. And those were fine. They were Promus stents actually, and EF was normal. Patient presented good medical therapy, as you can see here, and has a three vessel disease. The RCA, LPL, both were LPL was ISR, and then calcific LA diagonal bifurcation. D1 a little beyond the ostium, ISR, and still positive FFR of the LAD because LAD appeared about 60% only. EF was about 50, and patient had a RotaSynergyDES of the RCA and LPL, two in the RCA and one in the LPL, and did well. Let's show the angiogram, what we did. Okay, show the angiogram first. Yeah.
Shamin,
So
good
this is
evening.
where
I'm Diman here. I will be moderating
Diman.
the session.
Beautiful,
Thank you
Dr.
very much.
Diman. Welcome.
I remember similar case you showed triple vessel disease highly calcified from your hospital in Jaipur, Eastern Hospital.
Yes.
Excellent.
Yep.
I remember till now. Yeah.
Yeah, in
How are
your
you?
meeting, that was a very calcific diagonal. Remember, we could not go
Thank you
through
very much.
completely.
Thank you. Thank
Yeah.
you.
All right, welcome. Okay.
Thank you.
Now let's
Thank
see
you.
here, Dr. Diman and the team.
Annapoorna ji, good
Yeah,
evening.
how are you? Good evening.
I'm
We're
fine,
starting
Annapoorna.
today.
Thank you.
Yeah.
Today is
Yeah.
International Yoga Day, so we just actually
Yeah.
had our yoga session in the
Yeah.
morning at 7 a.m.
Yeah.
with all the fellows and all the faculty.
Oh,
Having done
great.
that, now we are all set in the yoga mode. We are ready to go to do this live case.
Yeah.
So you can see the EF near normal,
Yeah.
50%. Yeah,
Yeah.
EDP was 10.
That's
And
very good. Very good. Well treated.
the right coronary artery with the patent
Yeah, two
stents. I think
stents just put a Synergy XD about a few weeks ago, completely normal after rotablation. Yeah, good.
and this is the left side.
Yeah.
Prox LED, you can see moderate calcium, and then actually there's a significant disease in the diagonal. There's also a stent in the diagonal, but the disease is proximal to the stent.
Yeah. Yep.
Good
And
evening,
the
Dr.
substance,
Shamin,
okay.
Dr. Annapurna,
Yeah.
Dr. Dhiman. This is Dr. Ajay Swami. I don't know if I'm audible. Wonderful
Yeah.
case.
Okay.
Yeah.
Looking
Yeah. You
forward
are
to see
audible,
what we...
Ajay. You have come. In the morning, you rang
He
don't be
didn't take
coming.
apical picture. Take the picture now.
Welcome, Ajay.
Fantastic.
Yeah.
Let's see
All right,
what the
Ajay
plan is.
Swami. Good. Ajay and
Yes, sir.
Diman both are our co-moderator for this. And now we are taking the caudal picture. We'll put a stent in the LPL after the rota. Last week, there is also very diffuse disease of the distal circumflex, which we left alone. And then we'll show the whole case is the LED diagonal today. Let's see. So
So,
that
what
looks
is your
quite good.
plan, Shamin?
So let's go to epicranial and we'll tell you the plan now. So clearly that we have taken two vessels have been taken up, cleared. Now go to our presentation. Go back to the slides. Yeah. So now our plan today is that we wanted to make a rota cut approach of both the vessels, the LED and diagonal, and LED is positive. The question is how much calcified it is. Angiographically is moderate plus. We have to see why the IVUS. And then we do a rota of both the vessels and then use a cutting balloon and followed by do the synergy DES in the LAD, knowing that the ostial diagonal not involved. There's already a stent and his lesion is before that, and use the agent drug coated balloon in the diagonal. So same, the concept of the side branch, not putting a stent and use the drug-coated balloon is the one we are going to test. Now, the agent is available in America now, has been approved by FDA about 2 months ago. And this is the case will appropriate with the proximal to mid-LAD disease with a syntax score of 22. But actually was syntax that time. Now the syntax score is about 12 and 13. So we are ready to do the IVUS of the LED now. Wire has been, direct wiring of the LED has been done. And Anu is doing the IVUS now, our
Come closer.
IVUS. And we actually used to have our Kiski, but now
Iski is on vacation, so we have Yulia. She
Yulia
actually
will
is the
be there.
director of our imaging lab.
Yeah. Okay.
Fascinating
So
strategy, Dr. Samin. Just two small queries. Number
Yeah.
one, is agent approved for de novo lesions or just for ISR?
ISR.
And second
So
thing-
agent by definition is approved, but remember we have used many cases with the de novo now. Although
Right.
the price has been an issue here, here is a very expensive. They made it $5,000, and there is a no corresponding reimbursement yet. Same stand, same cutting balloon, same drug code balloon, you have it in $400, $800 there, equivalent. Here it is a 5,000. Yes, the reimbursement may come up and then it will compensate for it. But right now it's a loss to the institution. But at the same time, we're trying to see this strategy. Now this one we can call it a peri-stent. It's like a stent, in segment.
Right.
Not necessarily in stent, so lesion, but again, it has to be then probably the neoatherosclerosis if in the segment, because stent was done, Promus is in 2011, so 13 years ago. And both, and therefore, the diagonal stent as well as the LPL stents were done so long ago. So, and now patient has come back. I think it may be more of an incidental finding. And so key is, this is where we are going to do in this case. Yeah. Okay, now what happened is that I do a rota on the, I was on the rota wire, didn't go. And now we are putting a wire side by side. Good.
There's somebody talking in the side.
Yeah.
You have to mute. I could not go trying to do the IVUS on the rota wire. We did direct rota wiring. So we'll try, now I did a run through side by side. We'll try to go to the IVUS on the run through wire now.
Just for the audience, the wire that we're using is the rotor drive wire.
Yeah, right. Road drive floppy. The floppy usually, unless it's ISR, we do a floppy and, tortuous vessel, as you know, the extra support is needed, particularly ostial lesion or very distal lesion, and many times in the ISR. And so it was a floppy.
We can
Maybe
start
the rotor drive extra support might have been better, but to get it, now flush it here. Okay, you have to flush a little bit.
Yes, I did.
Okay, what do you see now? So LAD lesion, whether it's a calcified or not, that is what we need to see, how much calcium it is. Second, FFR is 0.76 in the LAD. So knowing that patient did have some ischemia in the apico-lateral wall, maybe from the diagonal, I was not convinced that how bad the LAD is, but LAD was a positive FFR 0.76 3 weeks ago. So it's and physiologically significant and anatomically intermediate. Now where is the LAD lesion?
I mean, LAD, there is significant calcium, but not at the level of the disease. So at the level of the disease, that's all 360-degree calcium, but that is proximal and distal. Go where the tightest area is.
The
Yes,
tightest
yeah,
area
right
will
there.
be
Yeah,
here.
right there.
Right there, yeah.
Come back. Yeah,
It's a lot of calcium, yeah.
I know, but CSA,
Let's measure the area.
But that's always the happens. What should be the MSA minimum or lumen MLA corresponding to the positive FFR in this particular case. So here looks like that doesn't look like much lesion, but why? Angiographically there is a lesion. Are we exactly at that area? Just can we see the lesion again?
Yeah.
You want to take a good picture again?
No, we
You do a
did
dry
once in a
cine, that's
minute.
how much calcium it is. Take a better picture. It was not a good picture that time. Yeah.
Okay, ready?
So 1 second. No. Lung shield. 1 second. Yeah. And we are, remember to see the calcium, you have to be a dry cine and then inject.
Go.
The lesion angiographically significant. Where is the lesion, guys? You have to go to the actual lesion. And this was the FFR significant lesion there. Everybody agrees? Any question
Yeah,
about
100% agreed,
yeah,
Shami.
good.
There
Good.
is no doubt
1.75. Go.
Okay,
angiographically and
175.
physiologically both are significant
Yeah.
lesions.
Yeah. Now, diagonal definitely is no question on the diagonal, and that is before. So we'll do the imaging. You want to finish the imaging of the diagonal also now or later?
I don't think you need to image.
Okay,
For what?
that's fine. So out. Good. Uh, so
Okay,
as
so
I
we'll do
said that we did the RotaCut trial in which we use the rotational atherectomy combining with cutting balloon or high pressure, 60 patient, and primary endpoint was MSA comparable with the balloon versus cuttings, and we found no difference in the MSA. We presented last year, published in Euro Intervention, RotaCut trial. There was no complications, 60 patients, just to tell you that how good the techniques have become. 60 patients of the complex, the native vessel. No, none of them were ISR. Native vessel with a lesion length of 28 millimeter. All majority were severely calcified. Like 85%, 15% were moderate. And we have two patients or two or three patients, a little borderline CK elevation. Otherwise, no complication at 30 days. Event rate.
Excellent.
Yeah. So that was the. But only thing is the concept which has been prevailing, that cutting balloon before rotablation may give you better lumen compared to high pressure balloon, we could not substantiate. So it was no difference and then of course we are going to follow those patients for 1 year, although a small number, 60 patients. That is there any difference in TLR, but of which I doubt it, because major trials none of them have shown that rotational atherectomy will decrease your TLR. So therefore, the acutely were fine, no extra complication or no actual benefit. So you can make it a point that maybe not in every case you want to do a RotaCut approach. Maybe just a high pressure balloon is good enough in this day and age. Now, only the drawback there was because we wanted to see the effect, not the strategy, that we did not underscore or undersize the burr in the cutting balloon approach. All were like 0.3, 0.4 burr to RT ratio, but that burr size was equal in both the groups. So will be a smaller burr in the cutting balloon group would have been better, but better in what? The stent expansion still didn't matter. Remained same in both of them. So the safety signal was not there at all at the equal burr size used in both the approaches. So just to say that the concept is there, non-randomized data are there, but in truly randomized data, we did not show any benefit of this. Good. Now,
Fantastic information. Dr. Samin, what do you use in your daily practice for sizing? Do you
The
see
bar.
what you found?
just basically, I would say usually go 0.3 to 4 ratio.
No, somebody is talking in the side, guys. Please.
And then there's going to be like 2 hours.
Who is it that talking in the side?
Please mute.
Yes.
Please mute. Yeah. So key is what we learned, and actually very interesting point. One of our fellow, we assigned the task that does rotational atherectomy practice changed and outcome changed since IVL. So IVL was introduced in September of 21 in America. So now it's of course about 3+ years, and so question is, by IVL did we start doing smaller burr, and is the outcome different in the era of the IVL? So that's what we probably will hear from us in next few months, that what actually the data are. Okay, Anu, ready?
Yeah.
They're ready with a 1.75 burr in the LAD, although it may not do much here because could be 2.0, but I think. Yeah.
What RPMs are we using, Dr. Samin?
All 150,000. Remember the Rota Pro, which I set up. This is the device. I went to their plant and set it up as to our liking. That it comes up with the 150. You don't have to adjust anything. You go on, take it out. Yeah, you go on and it will be at 150, 155. You want to increase or decrease your choice, but it comes by the factory set at 150, 155. And that is what we use most of the cases. Yeah.
We are not planning to burn the diagonal.
No, we will. No, plan today is burr the diagonal also. So here we'll take it out. We are going to a cutting balloon of the LAD now. And then we are going to wire the diagonal. Our goal today is rota cut approach on both. Do the imaging and then do the agent balloon for the side branch. If lesions remain good. Remember all the cases of the in the drug coated balloon era is about 1/3 you have to do a bailout stenting. So in this particular case, it's a calcific, very tight lesion. And if it's not a good, then we will take away the agent and put a second stent. But if looks good, no, cutting balloon here. You just the 3.5, right?
Was there any drop in RPM pressures?
No, there was not. So I think ideally I would say that if I had to do this case, probably would have used the 2 bar. Yeah, 2. No, nothing more than 2 or IVL. That's true. This is a case. It's not a. Most of people will can just do the with IVL. Yeah. You can do it on the road.
So, Dr. Samin, if you remember when in the POBA era, the definition of success used to be less than 80% residual stenosis. Is it possible that the depth that we use for de novo lesions, we have 1/3 we need to bail out stent because we are trying for a 1:1 every time?
That is true. And particularly the 30%. Now, the goal is that we want to bring it down to 30%. So no longer our concept of the 50, so able to get 30, and so many times you'll just require putting another stent because you cannot get to that level. And tell us the burr is done, now you are putting a wire?
I'm going on the rota wire.
Okay. So we have a 3.5 cutting balloon for the LAD. And
I would do the rota. If you want to do the rota of the diagonal now before you cut.
No, the cut
is
okay.
Dissect?
No, it will not dissect. It will not dissect. We saw that when the rota cut, it's a 3.25 6 millimeter Wolverine, and we did not find any more dissections compared to high pressure. So question Anu was that why you want to do any balloon before stenting, so maybe just do the leave it here and go. But I think we learned that now they do quite well. With you do a good atherectomy, you have done the rotablation and then you do the atherotomy with this balloon. You have to go a little distal also, yeah. But don't go more like 10, 12 atmosphere. Now many people go very high pressure, which is okay. Remember the cost trial when we actually had the letter to the editor from Colombo's group to our rota cut, and they said that our problem in this trial we didn't get you had to go a little distal. That in this trial was that we did not go to high pressure with the cutting balloon. Remember in the COF trial they went 22 atmosphere. They undersized the cutting balloon and went to 22 atmosphere. And you know how many perforations were there? 3. There were 3 or 4 perforations, and we are 0 in 60. So question is, you can go to very high pressure, but then you may end up in having some perforation. So to me, 16, 18 atmosphere is a good with a cutting balloon. Good, very good.
Is it
dissection is normal.
Yeah. The balloon artery ratio 1:1?
Yeah, so we actually go to little minus. Actually, our teaching has been good. Both can come out. If you want to put wire there, you can go to rota. So our goal always had been a little undersized the cutting balloon for the main vessel. If it is ISR, then you go to 1:1 or maybe even slightly 1+. Yeah. Now, you want to wire directly with the rotor? How you want to do it?
The tip is probably gone.
So now we are going to whether we will go with our technique of the fielder fine cross or just the wire directly. We'll see. Get ready, fielder fine cross. Yeah.
Fascinating strategy. Many of us would actually finish the rota in both the vessels and then do the cutting balloon, but this is a novel.
That is okay too. No, I think that's maybe that it's a nothing wrong in that. This case is not, but sometimes if your lesion just became from 90% to 70 plus percent, maybe doing a balloon of the main
Get me the
after the rota is
clip.
probably
Okay.
beneficial in my opinion. But doing the rota of both the branches probably is fine, and the burr will be 1.5 burr.
There's a rota clip. Okay, good.
Our concern is pulling out the wire from a vessel that has undergone atherectomy and a cutting balloon. You lose access because if you have to burr the side branch.
Right. So that is always the issue on this, always remain the concern. And of course, if that is the issue, then we have to see what can we do. We have to optimize, and whether cutting balloon is going to call the dissection is the issue. But as I said, like this case, a little bit of dissection is expected, but nothing significant which will be happen, and this is what in this case happened. We used a 3.25 cutting balloon at 12, 14 atmosphere after rota, and was fine.
Dr. Sharma, is it okay to go with a guide plus or something to have a burr into the diagonal and then take it so that you are preserving the wire in the LED?
Yeah, so that's a good point. But remember, to have that, you need a 8 French guide almost.
8 French.
Or
8
2
French guide.
Yeah, 8 French guide. So we actually, I know that strategy has been written, but we have never used it because in our opinion, it was never needed. Okay. And we do so many bifurcation, rotas, and so.
We all
I think
have
it is a very tight.
So can I ask you a
Yeah,
question?
very tight lesion in the diagonal.
Yeah, so I think the rota wire is not making it. So I'll take it out.
Dr. Sharma, sir?
Yes.
Sir, I have a question. If you want to do rotational atherectomy, I'm Dr. David from Calcutta. If you want to do rotational atherectomy on both arms, like LAD and D1,
yeah.
Which vessel will you rota first? Because you have to pull the wire out after rota.
Yeah.
So
I would say the very simple, the main vessel is the one you want to make sure the results are the main vessel is good. So you'll do the LAD first.
Right.
Yeah.
Thank
you. Rare situations, your side branch has significant disease, angulated, access to the side branch is harder. You may have to do the side branch first and then go to the main, because main usually is a straight approach.
That's our strategy, Dr. King. Perfect.
Yeah.
Yeah, that's clearly the. It will also depend on the very tightness of the side lesion also.
So as a rule, what we do is whichever is more difficult is done first, and the simpler one is done later.
Yeah, that's correct. Absolutely, very good point. Okay, so now we need a fielder fine cross to cross it, and we are ready with the strategy, because this was a tight lesion. Those kind of things.
Fielder,
the rota will not go through this kind of lesion, even if the lesion crosses with the rota tip. Remember, once you get to the spring, go further and it stops because of the change in the wire. That spring tip is 0.014 and the rota wire by that time is 0.007, actually 0.009, but the tip almost become 0.005, 0.006. So that inertia, so the wire just at the spring tip stops there. So this is the usual our strategy. We just want to try the rota wire because already was there in the LED. That's why I tried. But this is the case. We'll always go what we did now. That user we are work fielder wire with the over the wire system. Whether it's anyone we have fine cross is our favorite one, but any other catheter can be used just to exchange it. Yeah. So question is, maybe we can ask our, of course, the panelists and more our audience, that will they do a two-stent approach? Yeah, the question is, two-stent approach or stent or the drug-coated balloon in the diagonal? That's, I think, is a good question that Paul may have a different opinion. But let's show the picture once again so everybody has that in their mind.
Sharma, what is the size of the stent in the diagonal that was put earlier?
Yeah, it was 2.75.
Oh.
It was 2.75 in the diagonal and it was a 3.5 in the LPL in 2011. Go. So right now we are going with the 1.5 bar.
Bring it closer.
What do you need now?
No, this is like, okay.
So
I'm making
Dr.
sure
Anup
it's
Gupta
good.
has voted that he wants a DEB in the diagonal and a stent in the LAD.
Okay.
Fine.
Now, other question is, let me ask you, what is the common terminology being used? You remember the whole controversy is happening again, like TAVI and tower. So a lot of people outside America use DAB, and we are using a DCB. And I don't know what will be the prevailed. So just same thing, like everyone, we used tower here, and outside is TAVI. Whether it will be a DAB, a DEB, or a DAB, or say DESP, DCB.
So in India
DCB is
also
not
we
a
call
good.
it as dabber, you know.
Finally, tower came back now, huh? No, but we just did last week, last Saturday, we did a symposium actually on Friday. First time, I had 10 cases. All cases were calcific bifurcation. All 10 were atherectomy, 9 were rotational atherectomy, 1 was orbital. Of course, all of them I guided. 9 were IVAS, 9 or 8. I think OCT was 1 or 2.
No,
But majority with the IVAS.
three OCTs.
2 OCTs and 8 IVAS.
Three OCTs.
Oh, 3 OCTs, okay. So all were imaging guided, 10 all has atherectomy, and of course IVL was done in 4 of them, and that's our real life. 40% of cases after atherectomy getting IVL at Sinai. Just same idea is a smaller bar, and then Saturday, then we have the TAVI now with the Sun Pharma and Edward. So they still call it a TAVI now. And that was the third time in the row. Third year we did live relay of failed surgical valve. Saturday morning. Okay. So this is 1.5
Another
bar
vote
ready.
for the provisional strategy. Another vote for the provisional
All right.
strategy.
Okay. So good. So I think that's had been our goal also. Let's see how much we succeed, but we should get a 2.5 cutting balloon and then we'll see. Okay.
Test.
Let's get the burr first.
Okay, good.
Okay.
Fine.
Same push and
So
pull.
just for the
So
audience, this is a 1.5 again. Earlier was a
Pull back
175.
the
175. Yeah.
pull back the wire back a little bit. It's too distal.
And also I say that if the wire tip is in some side branch, make sure you pull back because that will cause a perforation because the wire still moves. Now once it curled up like this, that's okay. But if the wire tip go to a small branch, we just had actually a few weeks ago here at Mount Sinai, that the wire remain in the side branch.
Can you?
Yeah, I'm coming. Yeah, the wire remain in the side branch tip and then cause the perforation. Good.
Pull back a little bit more. I think.
The wire is okay. Yeah. So then it start going into one branch. Good. Okay, 3 steps. Our same.
Move the knob backward forward. Okay, that removes any tension between the Teflon sheath and the bar. Y connector backward forward. Any tension between the bar and the wire, and then we will test on the dyno. Yeah. It's a large bar for a side branch, so let's go very slow and packing motion.
Guys, 1 second. Off the Dana glide and make sure we increase the speed.
No,
Yeah, go.
Not connected.
Go now. The connect. Go. Go. Don't worry.
It was okay.
No. Good. Go. Good. Very good.
Okay.
Yeah, same 150. Good. 20 seconds. So we said clearly the hemodynamics, systolic pressure remains always in triple digit, cannot go less than 100. Second, 20-second back and forth motion, little different than orbital. Orbital you can keep going forward for 25 seconds. Here packing motion, in that 20 seconds you're doing like 7, 8 times packing motion.
Here the pulse decelerating at the calcium.
Yep, exactly. So it's still just about 2,000 head. Remember, if the open yellow will come if 5,000 and the red will come if it is 10,000. So it's not the or very stall. Yeah. So it still has not come.
Advance the wire a little bit.
Okay. I'll advance the wire when you are doing it. Go. Keep going. I think you're there. Just polish it. Yeah. Yeah.
No, somehow. Okay.
You're in the stent already. Yeah. Ready?
Yeah. Start
Good.
coming out.
Yep.
Okay. I will take out the wire.
Yeah, take it out. Yeah.
Okay, give me the field and the run through, okay?
And now we are going to do, we are done with the rota, remove that, and then we are going to do the.
Dr. Sharma, there was some reasonable drop in the diagonal?
No. It was just 3, never more than 5. Remember, I mean, it was less than like 3, about 3,000, and came very nicely, 1.5, went through, and we are just going to pull back those wires. Now, question is, before doing the cutting balloon of the side branch, AK, you want to do IVUS of the diagonal?
Can do it.
Shall we
Will
wire
IVUS
the
ready?
LED before the cutting balloon, Dr.
Oh yeah, absolutely.
Yeah,
We are going to wire both
First
of them now.
we are rewiring both the branches.
Both the branches, yeah. Now we have to rewire both. Good.
So that's our workhorse wire run through in the LED, and then we will go with fielder to the side branch, which is a diag.
And we are 2.5 cutting balloon. Yeah.
Fascinating. Some people actually put in a micro catheter into the main branch while they are burying the side branch just to protect it in case you have a complex bifurcation. I wonder if...
but remember the micro catheter, but same thing, that if there's no disease at the ostium. Remember, if there's no disease at the ostium, the rotablation will definitely, guide.
No, they are talking just bifurcation lesion.
No, I know, that's what I'm saying. The bifurcation, that you cannot do the rotablation of the side branch, even with a micro catheter or guideliner, people have put it. The only problem is, if there is no ostial disease, if there is ostial, the rota will shave your the plastic. So, but we, as I said, we do the highest number of rotablation in the globally. Nobody comes close. What number we do? About 60, 65 per month. At Mount Sinai, and I can tell you we have never had a situation because we'll approach as exactly spoken, that if there's very tough lesion, you take care of the side branch first and then you do the main, and then after the atherectomy we do a balloon many times, so that you have the lesion is stable. Okay, now we are ready for
IVUS?
Yes.
IVUS. Yeah. Show the IVUS, please.
Yes.
Good. Good. Okay, let's study the IVUS.
Right.
So that's a tight.
What is this?
This reverberation probably results of our, right?
Yeah, go back.
360.
Yeah, right there. Yeah,
Very
360 calcium.
It's still circular calcium.
Still circular, no break. Well, there's a little probably break here.
So that's okay. We expected that.
Yeah.
And we are, let's see, we'll make some cut in. And then remember,
what is the, so the vessel size is almost 3.0.
Yeah.
Right? Yeah. So if you take
let's cut a 2.5. We have the 2.5 cutting balloon now.
Won't do anything.
Yeah. No, let's start. Once we have opened it anyway, if need to be, we can see if the good lumen comes. Then we can use a 3.0 agent. 3.0 balloon will take. Agent balloon 15.
Won't do anything. I'm just telling you.
Go. Get a 3.0 12 or 3.0 15 high pressure balloon also. Let's do the cut with that 2.5. Because it's very, very circular. You saw that 360-degree calcium.
Yeah.
Yeah, good. Don't open anything yet. The question is whether 2.5 will do anything to this lesion, but I think the lesion is quite significant.
Even IVUS had trouble.
Even IVUS had a trouble at that place, remember, to go in.
Yeah, despite rota. You see that?
You want to open it here?
No, I want to do
little low pressure. So anything? Okay, take the wire back.
Wire back and rewire it.
Shama, will 312 be better off?
3 what?
Yeah, 312 could be okay. Yeah, we'll take a 312 balloon also.
Okay, good.
Yeah,
So it was just a crisscross. If you see there, initially there was a crisscross. So I pulled back the LED wire and rewired the LED. Now you see on the dry cine, you can see the separation of the wires. Yeah. So now the question comes the same, which you want to rewire. So here LED is straightforward. So very easy to rewire the LED. So if you want to rewire the branch, take care of rewire the branch that is easier than the side branch. Sometimes side branch could be easier, main vessel will be harder than rewire the side branch. This essentially was crisscross.
Great point.
Yeah. You have to go a little distal. 16. Good. Yeah, you know. Yeah.
Dr. Sharma, one quick question. Do you use timer when you use this cutting Wolverine or whatever?
No, not with the Wolverine, but we use with the agent balloon timer that we need to leave it for 60 to 90 seconds. Yes. And you know that for the long balloon inflation, the company, they just have approved, FDA has approved the perfusion balloon again. Those who are in the past, in 90s, early 90s, remember stack perfusion balloon? How many people have used the stack perfusion balloon at its time? So it's a different company. The Teleflex just got approval of the stack perfusion balloon. So they'll come with that now. And to me, I think the use only will be the patients with the go on to do osteum once again. Good, one second. Once again, very early. Yeah. So at this level, yeah. Good. So it will be in the perforation case. You want to leave the balloon for half hour, 20 minutes with the perfusion balloon. That probably will be the only indication for if it is available clinically soon.
Done.
Okay, so this is
the
we are
pulling the blade back and rotating it and putting it back.
Yeah, that's what we did. Yeah, I think it has shown better results. We have seen that always.
Yeah.
Yeah.
Just wonderful.
Beautiful.
Wonderful.
Good.
Wonderful demonstration.
Good. Let's. Yeah.
Dr. Sharma,
Now what you want to do now?
cutting balloons? How long do you inflate them for?
Yeah, no, I think this is about 20 seconds, but not way too long. But I know that longer balloon inflation has done better results with the angiographic point of view, but we don't worry about that nowadays because we do the stenting. So question comes in here, looks very good. I think we do the IVUS just to say that the cutting balloon has made some cuts. So we definitely found one of the point in our RotaCut trial that in the cutting balloon group, the cut of the calcium fracture was higher in the cutting balloon, although again this is very mechanistic only compared to the high pressure balloon. So Rota plus cut has a higher calcium fracture in the RotaCut trial, significantly higher. But
So
other
do you mean
outcomes were not
high pressure
different.
balloon as, sorry, do you mean high pressure balloon as OPN balloon or
No,
balloon
not
going
opiate.
up to higher
Yeah,
pressure?
yeah. So same high pressure non-compliant balloon going to 20 atmosphere and so. The opium balloon is available here. Yeah, opium balloon is also available in America now. But again, it's the cost issue. It's a $1,200. There is no extra reimbursement for it.
Okay, let's ready with the IVUS again.
Okay.
The RotaCut
Still
trial,
not.
we have left main patients.
This will be interesting.
Yeah, it's still not going. I was.
What did you do? Let's not push it. Okay, good.
Good. So always pull back and just go with the speed. Go to the IVUS on the center, please.
Are we ready? Ready?
Okay,
Ready?
let's go.
Can we see the IVUS on the screen, please?
Sometimes it's too fast. Okay,
Too fast.
stop. Go back. Do 1 millimeter.
Okay.
Yeah,
But
we want to
there's
do 1
some-
millimeter.
Yeah,
Yeah,
nice cuts
regular way.
already there.
Yeah.
Okay,
So I think there is a nice cuts.
Okay, good.
Let's see again.
Fascinating. Fascinating.
Restart.
Very nice.
One
Good.
second.
Go.
We are going. One second. Here.
It's not 1
Yeah,
millimeter.
The cut.
It became fast.
Yeah. Very nice. Very
Why
nice.
did you go to the 8? We said 1 millimeter.
Yeah.
Huh?
1
This was not
millimeter.
1.
It's
Yeah,
slower.
please.
Huh?
4. You went to
4.
4. See? Okay, off.
Stop.
All right,
We
don't
have
do
to
too
stop.
much.
Yeah.
Have to stop.
Otherwise, artery will have IVUS toxicity. We don't want that.
Ultrasound.
Ultrasound toxicity.
Instead of giving a drug, we'll give ultrasound.
Ultrasound, yeah. So tell us now, who can
Okay,
analyze this a
we're
little
going
better
back.
now? Tell us
Yeah.
exactly what we have done or not done.
Back to the calcium we saw right there.
Pull back, there. Yeah.
Here.
Back,
These are the nice
Cut.
cuts.
Look at that. Remember earlier
It's,
was total circular. Now you got at
yeah,
least one,
yeah.
two, three cuts.
Textbook.
Three
One
cuts.
on the
Very
top,
nice.
six, three cuts,
Very
clear
nice.
cut, three cuts.
Very nice.
Yeah.
Beautiful.
And three cuts corresponding to 3 blades of the 2.5. If the 3 plus has a 4 blades, we would have seen 4 cuts.
Yeah.
But nice.
Wonderful.
Yeah, nice.
Look at
Okay.
that.
So let's do the agent balloon and then we put a stent across. Anu, okay with that plan?
Yeah.
Yeah.
I think I would want to do more in this vessel.
No, that's okay. Agent balloon. What is this now? No, is it longer than 15 or no? I think
We
15
have
will be okay, right?
minutes. Maybe we can extend. But
Yeah.
would you like to
Yeah.
do a
No,
3-millimeter
we'll be
NC
done.
balloon
No,
high
we'll be done.
pressure before
For
the
the LED?
cutting?
You mean
No,
for the diagonal or for the LED?
for the diagonal, sir. Before putting the agent, would you like to put in a 3-millimeter NC balloon at moderate to high pressure before putting the drug-eluting balloon in the diagonal? I was wondering.
Yeah, we have that actually. We opened up
The
earlier.
normal distal vessel is 2.8.
Yeah. 3 will
Maybe
be okay.
275.
Approximately. No, 3 will be okay. Moderate pressure here. Because it was at
Okay,
2 point.
but agent what you have? 20
3.
only?
3
20.
or
What's
20.
the shortest?
No, not shortest. We need longer.
No, I'm asking. What?
12.
12.
12 is the shortest, yeah. So we need 20. Go. Yeah, actually we have up to 30 and 40 millimeter length, but we have selected sizes we are carrying. So you're right. So we are going to optimize what is the MLD of the minimal MLD of the diagonal.
Minimal. One
To looks
second.
good actually.
Here. This is not showing. It's all.
Okay, so we took the advice. We are going with the 3 or 12. Little high pressure in proximal area, particularly where there was the tightest disease was there.
Okay, bring the agent balloon
Yeah,
so we can
come in.
finish the
Yeah,
case. Yeah,
yeah.
go.
I
Open.
think
What
it's
you'll
a
do for the
beautiful
LED?
demonstration.
Nothing. We'll just stent across.
No, what length exactly? Synergy. This has to be a
28.
synergy.
3.528. to the LED.
3.528 synergy XD. Is there a
Expansion
no
looks
megatron?
good
Go
if we
for that.
have
Yeah, go for that. And you see the ECG there? Yeah, all good.
Open.
Open.
Get down.
I think angiographically expansion looks good, doctor. I mean, although
Very
we
good.
are
Yes.
Okay, go
Agreed.
here now.
thousands of
Yeah.
kilometers away, looks nice.
Yeah. No, but that's correct. It looks good. Yeah.
Okay, open the agent now. The stent is ready? Okay. Yes. Yes. Somebody was asking a question.
Yeah.
Yes, it's Dr. Praveen from Bangalore here. Now,
Yes.
on angiography, we'll take a cutting balloon, 0.5 size less, but with IVA's guidance, would you still take a 1-to-1 or less than?
Yeah, so I think we'll take 1-to-1. Yeah. Still 0.2. I think we have seen the perforation. So key is that the drug coated balloon. I tell everybody they can see it up. That use it with the syringe way. So don't touch the drug balloon. So just use with the syringe to advance in the back and now go in. It's a precious because of $5,000.
Sharma, why did you prefer hydrophilic YF as side branch?
Well, we actually always have been, and I know the data actually, remember the electron microscopy of the side branch actually have shown whether hydrophilic.
No, first hydrophilic wire, you see that it's easier to cross.
Yeah.
Now, if you're asking the question about the jailing,
Yeah.
then you can say
Yeah.
that.
Both.
Yes.
Okay, so question comes in hydrophilic for the side branch, which will be left later when we jail it, and a lot of people believe that there is a coating comes off and this. I know electron microscopy that does not happen. Second the issue remain is we are upright timing, yeah, and the second issue remain that we always have seen it's much easier, does not get stuck, no jailed branch. You start at 20. So usually do about 60 to 90 seconds based on what it is, yeah.
App slides at the end.
So do we see any ECG changes?
Nope,
No,
nothing is
that
coming.
You can see.
Yeah, actually now we are seeing some ST depression, yes. T wave changes, no ST elevation, and the patient is nicely, I would say, anesthetized by our nursing team, sleeping nicely, which I always say it's a good thing. Not yet.
Yeah.
What is the time there? 60 seconds you leave it, or 90 seconds, or what?
I think it's a minimum of 60 and a maximum of 90. Less than 60 is suboptimal, more than 90 is useless.
Yeah, agreed. Good. So we actually trying to go.
is 60.
60, yeah. Yeah, 60 is good.
Okay, ready? Done.
Yeah.
We are about 60 seconds. Okay.
Yeah. Take a picture. Beautiful. Okay, we can leave that wire and we are going to put a stent across. And once that is done, then we'll go up and our plan, exactly that is what we planned. Rota cut of both the branches, agent balloon to the side branch, and which actually got a good favor from, our audience really wanted that provisional approach rather than having a two and a stent of the main vessel, which we are doing now. And the whole case remain that it does not get now the branch pinched extra.
So we're going with the 3528 Synergy to
Synergy
the
XD, yeah. And XD is available now.
The side branch, fire.
Synergy XD is available, although the data of the side branch leaving, as you remember, there is not much difference, except that recovery of the side branch once it closes is a little better if you leave the branch wire there. Cine?
Yeah, no, some die. I don't need Cine. Yeah,
Looks
good. Okay, go up.
Go up.
We're going up.
Yeah, I know.
These guys, they don't wait.
Go up here. So we usually deploy them at 16 atmosphere, let it be inflated for 5-10 seconds, and then you take it out. 2 inflations. Same thing we start doing in many of the TAVI cases. 2 inflations, because that seems to give a better the TAVI valve expansion also. Good.
Sharma,
we can do the IVUS of the LED now, right?
Yeah,
rationale behind going for a higher pressure deployment?
Yeah, no, means 16. So I think so many times you don't have to do the post. We go with the 16, so we are not dilating again, and we have seen with the 16 is okay. You don't go beyond. Beyond you get more perforations and so. But not perforation, I mean dissection. But 16 has been, so many times when you have done already so much work at baseline that you now don't need to have the post dilate, although you can if need to be post dilate, but a lot of people will do a 12 atmosphere, 10 to 12 and post dilate within it. That's another approach, but ours is like 16 and we have post dilatation. Everybody is different in our lab, but I have a post dilatation only 60-70%. 30 remaining 34+% no post dilatation, because everything looks quite good because you have done a lot of like this case we did a lot of plaque modification. We have done the cutting balloon, we have done the high pressure and after rotation atherectomy, and therefore it's okay to just leave it. So let's see, we ready with the IVUS again? Put the IVUS on the main center please. Yeah, good.
Okay, let's go.
Flush first.
Simple, 1 millimeter.
Yeah, 1 millimeter, please.
1 second.
Are we 1 millimeter now? Yes. Good. Flush here. You don't have the flush.
We did. Okay, start.
Flush? No?
Yeah, we are
Good.
very good.
Okay.
Good. That's a normal vessel.
Yep.
Now we start seeing the
We're gonna assistant.
yeah,
Distal edge.
Yeah, distal edge is good. No
Looks
dissection.
great, yeah.
Not malopposed, fully opposed.
Good expansion around calcium.
Nice expansion. One thing
Distal, proximal.
What about level of the diagonal?
right there, now we are at the level of the
Right
diagonal.
there, right there.
Yeah. But proximally also you see that?
So we're still going.
Well opposed. Proximal edge.
Proximal edge,
There's a
yeah.
little bit,
No.
once, you see that at 11 o'clock, there was some malopposition.
Yeah.
But
one strut length is okay. It's allowed. Now let's take a
No,
good
this
picture.
is calcium,
We
right?
did the picture already.
Okay.
So let's ask our experts here that do we need to do any post dilatation? The wire from the diagonal has been taken out, and angiographically it has been like this. This is
I
the
think it
angiographic.
looks beautiful, Dr. Samin.
Yeah.
Post dilatation is
Looks
entirely up to you.
beautiful.
I feel the catheter
good,
was
yeah.
a little oblique.
Yeah.
That is
Go
why
to Cordon.
we got the appearance of malapposition. I think it looks good to me.
Yeah.
Is there any pinching of the
Fantastic.
diagonal?
Yeah. So question
Diagonal
is this.
looks good. Pull back,
Yeah.
pull back a lot. Pull back.
Yeah.
There seems to be some pinching of the diagonal. Is it okay to leave it like that?
Pinching.
No, that is healthy.
Yeah.
That's a normal look of the side branch after provisional stenting.
Yeah. So I think it's the same.
So the reason is, as long as you have TIMI3 flow and no chest pain, no EKG changes, none of the above, right?
Yeah.
Okay, you good?
Yep.
You did?
Go. Yeah. Did nitro everything taken care.
Okay, good. So this is a caudal, then we will give them a cranial. Go. So nice proximal.
Yeah. Die. Little flush right there. Let's do another one.
Go. Okay,
Very nice.
looking
Very
good.
nice. Go to epicranial or aleocranial. Yeah, you're right. We just have to see the ostial diagonal in some view. If there is some question, then we go back and do the kissing balloon. Then definitely we have to use high pressure and so.
No.
Okay. Ready?
Okay, good.
I think this is okay.
Yeah,
I
there
think
is
it's
TIMI3
good.
flow
This
and-
is, yeah.
And remember,
Anything
second
we do
point
is
here.
going negatively.
flow
Right.
and,
No, not only that. Remember,
You
with the
also did it
drug-coated
at-
balloon,
you should
whole
not-
idea was no IVUS and no post-dilatation if possible. Unless it is so, there is little osteal disease. I mean, we'll give a little nitro and verapamil. That will take care of it. If everybody is okay, we are done here, and we can start your lectures series.
Fantastic,
Dr.
Dr.
Sharma,
Samin. We
just
must
one
Any other
congratulate
question?
you.
Let's.
Yeah, yeah.
Okay, can you
Any
show the
questions, let's
app
have.
slides finally?
Huh?
Tell him to show the app slides.
You have the
Dr. Sharma,
slide.
just one question for the sake of this thing. How often do
Tell
we
them
have
the
to
later.
assess the functional significance of that side branch? We have
Yeah,
done so
very
much
good point.
Rosuvastatin or-
Yes.
Yeah, very, very good point. We know that angiographically, even if you look 70-80%, the positive FFR will be only in 18-20% of cases. We all are very well aware of that point. This is mine, old one. This is the new one. That's what I'm
Very
saying.
old.
Yeah.
There's a new one.
Question is, we rarely do. And remember, to answer that, we had done the
There is a
DK
new
Cross
one.
6 trial. Remember, it was a strategy of FFR guidance of the side branch, and they came up in the end that didn't help at all. So I think, to me, we used to do a lot of FFR of the side branches. I had not personally done FFR of the side branch in 2 years. If angiography didn't look bad, we went in. If did not look bad, we leave it alone. But did not guide based on the FFR since the DK Cross 6. So therefore, like what? Little slow flow. You see a little dissection at the ostium. You see some EKG changes, patient having chest pain. Then I would just decide there. Not just by looking at a hazy lesion like this case and decide based on the FFR. We stopped doing it because there is no trial to support that.
Now you put
And most of them have shown that it is the basically angiographic the FFR will be negative in majority of those cases, irrespective, even if your side branch stenosis is 90+%. Many cases. Yeah. So we are going to show the last app. We got 2 minutes, 2-3 minutes. So Anu wants to show the updated of the app. This is the updated slide? No. So we actually have multiple apps which have come, all
Oh, yeah,
educational.
all 13.
13 apps, over million or 100,000 plus downloads, and few of them just added on, and we wanted to update our interventional community with another big educational endeavor which Mount Sinai is taking. And these are, these apps we develop ourselves, and we put the money into it. The personal, philanthropic funds. If you have the slide, this is the one.
No, that's the only one he has. Yeah, you can show it there.
I have the other slide. We may have the symposium, or the last one could be.
Maybe you can come back about at the end and show it.
No, we can show that. Yeah,
no, this. So if you go to cardiologyapps.com, go. Okay, he took it down. So you will have all the things that we discussed here, bifurcation, various bifurcation technique, and the same question was asked: when do you take care of the side branch? So we have discussed all these steps in the app. So the bifurcate, we have two. First one is just illustration, and 3D is animation. So all the steps have been discussed with animation. So all the questions that were discussed today was there. Exactly when do you leave a side branch? Means you have the side branch that looks like this. It is this was about ostium, 30 to 50% ostium, but more important, TIMI flow was good, no EKG changes, no chest pain. So that's the time we can say, okay, we can leave this side branch alone. Other than that, I know we did the drug-coated balloon so that we don't have to go back. But this is a kind of a side branch, the typical look of a balloon, cutting balloon or a balloon angioplasty, and you've done a provisional stenting. All the steps of rotational atherectomy and orbital atherectomy have been discussed in the calcific. So it's a simple, all the techniques that are nicely outlined, and it's a fast read. You can have it on your either iPad, your PC, or even on your phone, so that all these steps can be gone through with these apps. So calcificate, bifurcate is a must, because what interventionalists face is these are the kind of lesions that we see. Then there is a guide wire. All the guide wires that we use have been outlined there, especially what would you use for a CTO and a non-CTO lesion. And new one that just released during our symposium was called as a device. Okay, device app, device aid it is called. So all the cath lab personnel, which is technicians, nurses, should have it, all the devices that we use in the cath lab, starting from the access to the closure, whether it is radial or femoral access. Everything is discussed with the guide catheter, regular wires, guide wires, balloons, stents, thrombectomy devices. All the devices of the cath lab have been discussed. So any questions you have for us?
Oh, thank you very much. Thanks for your excellent showing the cases, and it's like previously all the times you were excellent, superb. I'm Dr. Kahali here. Thank you, Annapurnaji. Thank you, Dr. Shamin Sharma. Excellent cases. If there is any question, just I wanted to make a point, Annapurna, that Dr. Antonio Colombo and Ajim Latif had several papers, and they have shown they have done FFR just for experimental purpose, pass the VAC. And even if the lesion is up to 75 or 80%, in majority of the cases, more than 90% of the cases, the FFR is negative. So if it is only the side branch pinching is 90% or more, we intervene. But even if there is TIMI3 flow, we don't intervene. So your point is very well taken. And all of us agree with you that, we shouldn't disturb the side branch by doing another thing. And thank you very much for coming out with these beautiful apps. They are excellent for the learning purpose. Thank you very much, Dr. Shamin Sharma and Annapurna.
Keep going.
For your excellent
Keep going. Yeah.
apps. It's really very, very good.
Yeah. So this is, you see, these are all the new ones.
Yeah.
So if you see that IVUS also, now IVUS we have shown, though many people don't know a lot of IVUS, how the lesion looks and all that. We have IVUS aid and OCT, and both also for the learning purpose we have quiz and then case scenarios that all the live cases we do, and the cases that we do. That is case scenarios of in both this IVUS aid as well as in the OCT. The other important one, which is called complicate, 1, 2, 3, 4, 5, sixth one, where you see like a heart, that's complicate. There are over 80 cases of cath lab complications. All the complications that we face, which includes perforations, then slow flow, various kind of complications have been discussed in this complicate. Means it's each one is a case where we will tell you about the case, patient history, EKG, all the angiograms, and how we manage these complications. So it's very good. It's a learning for the upcoming interventionalists is exactly how to face this complication. All these cases, everything that is out there is our work from the cath lab. So it's a lot of time and effort that has gone into how to get this apps being done, and all that is out there is our experience, especially the complicated management of the patients if any kind of complication happens.
And the guide wire aid actually is very important because everybody keep asking which guide wire, what it is. So every wire is there in the guide wire aid. Every wire is there in the guide wire. Right?
Yeah, I said guide wire. I said the guide wire is a last one. G.
Start putting the name underneath also.
G. No, we do have.
So with
okay.
that note, we are concluding
Excellent,
right at time,
excellent.
full 1 hour, and I'll see you in. You start the Diman or Kusar is conducting now. Start the presentation, and I'll join you in about 5 minutes.
Okay. Thank you.
Thank you.
Thank you. Thank you, Ed.